All right, welcome back everyone. So let's take a few minutes and talk about airflow, right? And factors that are going to influence airflow, right? So airflow is something we've kind of already alluded to and we've talked about in previous parts. This is simply the movement of air into and out of the lungs, right? When we inhale, when we exhale. We've also talked about kind of one factor that influences it, and that's the pressure gradient, right? So as you change volume, you change pressure. This establishes a gradient from one area of high pressure to another area of low pressure. What we'll also consider is something called resistance, right? And so you can think of resistance in the airway in a similar manner to how you think of resistance in blood vessels, right? So it's going to change based on maybe the size of the airway. Okay, that's kind of one way that you can think about it in relation to blood vessels, right? So when we're talking about airflow, you can think of a formula, and this is the same formula we looked at whenever we did flow of blood, right? So F equals flow. The delta P is referring to the change in pressure, so the gradient. So one area that has one pressure, another area that has another pressure. What's the difference between those pressures? So the gradient. And then the R is resistance, right? So the way you interpret this formula, F equals delta P divided by R, or over R. The delta P is in the numerator, so this means that the greater the pressure gradient, the greater the flow. So it's directly related to the flow, the pressure gradient is, right? The R, the resistance, is in the denominator, so this means that it's inversely related to flow, right? So if you increase resistance, you decrease flow, or the rate of the flow is going to slow down, right? So the gradient we've already talked about, right? The gradient essentially changing the volume of the thoracic cavity, which changes the pressure, which causes a localized area of low pressure in the lung and an area of high pressure in the atmosphere, right? And air is going to move from high to low, right? And then when you exhale, the exact opposite, right? Higher pressure in the lung, lower pressure in the atmosphere, air is going to move from high pressure to low pressure, right? So think larger lungs versus smaller lungs, okay? The resistance is another discussion, right? So resistance is factors that are going to change or that are going to increase the difficulty of moving air, right? So the pressure gradients, that a smaller gradient versus a larger gradient, that doesn't really mean that it's more difficult for air to move. It just means that it's not going to move as much, right? Because there's not as much of a force driving it, right? So resistance is going to make it more difficult to move air into or out of our respiratory tract, right? So this can have to do with the elasticity of the chest wall, right? So you can imagine if you're not able to expand your chest wall and lungs, it's going to be difficult to bring air in, right? This can have to do with the size of our bronchioles. So if you're in a vasoconstricted versus a vasodilated state, so this is similar to like our blood vessels, and then collapse of alveoli, right? If we're not expanding our alveoli, it's difficult to bring air in, right? So if we look at each of these individually, we see decreases in chest wall, right? So the bones, the cartilage that makes up our chest wall can kind of harden and decrease in elasticity over time. So again, you may develop arthritis over time. You can have pulmonary fibrosis, in which some of the normal healthy tissue in the lung perhaps is replaced with additional collagen and connective tissue, and this is not as elastic. It does not allow for the expansion, thus increasing resistance, right? And then maybe also some type of skeletal malformation, right? So like a scoliosis, right? So a minor scoliosis, right? Slight lateral curvature probably isn't going to affect breathing significantly, but significantly large malformations, so major lateral curvatures, can influence the ability of influence our ability to bring in air, right? The size of the bronchiole is also going to affect this, right? So this is primarily occurring at the smaller level, right? So small bronchioles. You're not changing the size of the trachea. You're not changing the size of your bronchi, right? Your main stem bronchus, secondary, tertiary. You're changing the size of your bronchioles, right? There's more smooth muscle there, right? And so the smooth muscle, just like it could change the size of our arteries, our smaller arteries and arterioles, the smooth muscle in our bronchioles is also going to change the size, right? So when you have, and again, this smooth muscle is arranged in kind of circles, right? Circular arrangement. So when the muscle, and again, this is smooth muscle, remember. When the smooth muscle constricts and contracts, it's going to cause bronchoconstriction. So it's going to decrease the lumen of the bronchiole, and that's going to increase resistance, just like decreasing the lumen of an arteriole or an artery increase resistance to blood flow and increase blood pressure, right? So it made the heart have to pump harder in order to move the blood, right? Same basic principle for air in our bronchioles, right? You bronchoconstrict, you increase resistance, it makes it more difficult for air to move in and out. You bronchodilate, you decrease resistance, it makes it more easy. It makes it easier for air to move in and out, right? So you can think of some of these various things, right? So sympathetic stimulation, so autonomic nervous system, cold, mucus inflammation, asthma, all of these things can influence the state of our bronchioles, right? So whether they're constricted or dilated, right? And then last thing you can look at that affects resistance directly is the state of the alveoli, right? So are they collapsed, right? So we have a cell type called type 2 alveolar cells. They're also called type 2 pneumocytes, right? And these type 2 pneumocytes produce something called surfactant, right? And surfactant helps to reduce surface tension in the lung, right? And so if you don't have this surfactant, this kind of lipid substance that coats the inner lining of the alveoli, if you don't have that surfactant, then you have increased surface tension, and you can end up with increased resistance because these alveoli are not opening, and thus air is not moving in, and that affects gas exchange and several other things, right? And so if this happens in infants, and this can happen especially in premature infants, right? So infants who are born prematurely, their lungs are not yet developed, and they don't have the mature type 2 alveolar cells, those pneumocytes, that are producing the surfactant, and so they can end up with something called infant respiratory distress syndrome, right, or IRDS. So this can be combated, however, with the administration of medication to the mother. Kind of, it's usually around. It's before birth, is what I'm trying to say. The medication, I believe, they typically give some type of glucocorticoid, and this can stimulate surfactant production in the fetus, such that when the fetus is born, there is a smaller chance, a smaller likelihood of them having respiratory distress. Right. Now, some other things that can affect the flow of air are things like the compliance. The compliance is essentially how willing, right, to put it that way, how willing are the lungs and the chest wall, how willing are they to expand, right? So if they freely expand very easily, there's no disease in the bone or connective tissue, no increase in surface tension, then there's a high degree of compliance, right? If they are fibrotic, right? If the chest wall is damaged, if there's some type of disease like costochondritis or something which affects the compliance of the lung and the chest wall, then the flow of air is going to be decreased, right? So you're going to have increased resistance, right? Now, there are several diseases that can result in this, and we've already mentioned several of these. So think asthma, pulmonary fibrosis that are affecting compliance and the size of the lumen, right? So all this is doing is this is ultimately going to result in more forced labored breathing, right? So you're going to have to use some of those additional muscles, additional extra muscles of respiration to aid in the movement of air both into and out of the lung, right? So you can kind of see a summary slide here of factors that are going to influence airflow. Okay. So again, recall that formula. Flow equals, delta P, change in the pressure gradient divided by resistance. So if it's in the numerator, it's directly related to flow. So larger the gradient, greater the flow. If it's in the denominator, the resistance, it's inversely related. So greater resistance, decreased flow, right? Or the slower the flow, right? So let's stop here. We'll pick up on our next part, and we'll begin talking about the movement of air into the lungs. So we'll talk about minute ventilation, something called alveolar ventilation, and then we'll get into discussions of specific volumes of air that we're able to move into and out of the lungs during different types of breathing.